Look at the architecture of modern healthcare billing. Claims are generated, routed, and processed through digital conduits faster than at any point in history. In fact, the average time it takes for an insurance payment to clear has dropped over the last year, falling to 55.2 days. This chart illustrates a paradox. On the left, payment speed is improving, but on the right, denied revenue spikes, reaching $48.4 billion in 2025. That represents a 25% increase in lost revenue. Money moves faster, but less reaches the practice. The driver behind this massive loss is a specific metric: clinical initial denial rates, which have risen. Insurance companies refined their payout strategies. They instantly clear simple claims, but aggressively reject complex ones. This scale of revenue leakage rarely results from incompetent coders. It stems from a failure to capture precise clinical information at the point of care. We call this the documentation gap. It is the precise delta between the medical care actually received and the details successfully recorded in the chart. The documentation usually exists, but it is incomplete, ambiguous, or lacks the exact terminology a payer requires to authorize reimbursement. Look at this matrix of medical records. Up to 30% contain revenue-threatening documentation gaps. A common variation is a vague diagnosis, omitting the underlying condition. Payers aggressively target these ambiguities, zeroing in on high-risk categories like sepsis. A physician manages a highly complex encounter, but without specific medical necessity language, the visit gets billed at a much cheaper tier. The financial consequence of these accumulated gaps is staggering. On average, coding inaccuracies put $11.2 million in revenue at risk per healthcare organization. Failing to translate clinical nuance into a payer's exacting standard is functionally identical to providing uncompensated medical care. When practices notice their denial rates climbing, the standard operational response is to push their existing billing staff to work the accounts receivable harder. This diagram maps the coding spiral. A claim generates, the payer denies it, staff reworks it, and queries the physician. The cycle repeats. The query causes friction. Doctors must recall details from weeks ago. 34% declare the condition indeterminable. The gap remains open. Every time a claim gets caught in this loop, it triggers a hidden administrative tax. It costs a practice between $118 and $136 just to reprocess a single denied claim. That overhead is entirely wasted when you consider that 84% of these denials could have been prevented if the gap was caught before submission. Treating documentation gaps as a back-end billing problem traps a practice in a cycle of retrospective rework, eroding profit margins with every passing month. Large hospital systems bypass this trap by building dedicated clinical documentation integrity, or CDI, departments to catch errors upfront. Healthcare Financial Management Association benchmarks show that organizations with dedicated CDI programs yield a massive 68% improvement in net collection rates. But smaller practices face a severe roadblock in replicating this model. They are competing against a nationwide talent deficit for credentialed specialists. The unit economics of an in-house hire are steep. A fully certified CDI specialist commands a salary between $55,000 and $75,000 before factoring in payroll taxes, health benefits, and training overhead. And turnover compounds the damage. Frontline administrative staff leave for higher enterprise pay at an annual rate of 33%, costing a practice up to $30,000 just to recruit and train a single replacement. Building and maintaining an in-house CDI capability from scratch is no longer a viable scaling strategy for medical groups. It is an unsustainable capital risk. The alternative model is to outsource the CDI function entirely. Practices partner with organizations like Staffingly, plugging a credentialed external team directly into their workflow. This solution is deeply embedded. The external specialists don't use separate software. They work directly inside the practice's existing EMR system via an encrypted VPN. This enables a shift from retrospective rework to concurrent chart review. Gaps are identified, and physicians are queried within 24 hours of the patient encounter while the details are still fresh. To scale this review process without creating bottlenecks, the outsourced model utilizes AI smart routing. As patient charts flow in, an AI node scans them, instantly diverting high-risk charts to human specialists. Predictive workload management balances the distribution,
ensuring charts never pile up during high-volume periods. Simultaneously, automated continuous audits scan the files to flag potential errors before reaching the billing department. There is a strict division of labor. Technology handles pattern recognition and sorting, while credentialed human specialists handle clinical judgment and formulate compliant physician queries. Combining AI workflow automation with dedicated human expertise is the exact formula required to process high claim volumes while keeping error rates below 1%. The financial comparison between these two models is definitive. On the left, an in-house setup towers at $55,000 to $75,000 a year. On the right, an outsourced dedicated seat costs just $20,748. Broken down, that guarantees a dedicated, credentialed specialist working in your system for just $399 per week. For practices needing multiple seats, volume scaling drops that price to $349. Beyond the direct cost savings, the outsourced model delivers operational velocity. A guaranteed 14-day go-live timeframe entirely eliminates the months of recruiting, interviewing, and onboarding delays. It also provides deep executive transparency. Practice administrators receive weekly KPI dashboards tracking throughput, query success rates, and return on investment in a CFO-ready format. This model flips documentation integrity from a burdensome, high-risk fixed overhead cost into an agile, easily managed operational switch. The macro threat of audit exposure is growing. Payer audits are rising at 30% year over year, subjecting high-complexity claims to intense scrutiny. Surviving this environment requires a shift in perspective. Clinical documentation integrity must be treated as a daily revenue protection strategy, not a periodic compliance checkbox. The medical care was already delivered. The clinical effort was expended. The resulting revenue rightfully belongs to your practice.